Hello, everybody. Can you hear me?
Yes.
Thank you. Good morning. Good morning, everyone. I'm Jose Cucalon Calderon. I'm a general pediatrician here in Reno, Nevada, and I'm an associate professor of pediatrics for the University of Nevada, Reno School of Medicine. I also hold multiple other hats, including being a past medical director for our local juvenile correction facility, Jan Evans, as well as serving as our state's National Hispanic Medical Association chapter developer, founder, and co-chair, current co-chair. I'm happy to talk to you today about youth in the juvenile justice system, where we come from, how we are doing, where we are now, and where we're going, or where we are going, or hoping to go. This talk is going to highlight national data. I'm not going to focus much on local data, if almost at all, but I do want to make two disclaimers about that at the beginning. Number one is that most of the things that I'm going to talk about are going to be common trends that you're going to see in your experience with justice, working with justice-involved youth, justice system-involved youth. And that demographic is going to change based on where you geographically work and how your populations are spread across your state or your district. So the information and the information is still going to be applicable. The only things that are going to change are going to be which group is represented at each one of your different districts. The second thing is that I am, again, a working pediatrician, and I am doing this talk from one of my exam rooms. So if you hear somebody, a kid crying, please forgive me. But this is where we live. So thank you, everybody. I have no disclosures to make. So we're going to talk about common national trends for youth in the juvenile justice system in relation to healthcare. We're going to talk about medical evidence available on the role of trauma and trauma-informed care and social determinants of health on children who go through the juvenile justice system. We're going to highlight some of the American Academy of Pediatrics recommendations, as well as the National Commission on Correctional Healthcare for their care. And then we're going to talk about data gaps and further research with some closing comments at the end. So I normally tend to refer everybody younger than 18, being a pediatrician, as children. So if you hear me reference children all the time, I'm talking about our population of juvenile justice involved youth. So things that we have that we know and where we stand currently is that the United States incarcerates humans more than anywhere else in the planet, and that is true also for children. We are a leader. We're the world leader in detaining and criminalizing youth and processing them as well. Justice system involved youth have a disproportionate representation for youth of color, with a total number in 2019 of youth of 36,479 confined in facilities away from home during that year. Numbers are good, and then this spread is going to be 74% of them held in public facilities, and close to half of them having been held in public facilities, and almost half of them being in local centers at different districts. The good thing is that things have improved. A lot of the things that we have put in place on how we support children and their families when they come in contact with when they come into the juvenile justice system has actually led to significant change. We have 58% less arrests since 2010, and after the all-time high in the 1990s. The largest population of youth that end up coming in contact with the juvenile justice system are going to be male, and there is a significantly disproportionate amount across the United States of these children identifying with one or another minority group, being ethnic minority, being or any other kind. Again, we have a decreasing trend, which I'm going to highlight in a couple of slides, okay, on total numbers, but we continue having an increase in the disproportionate representation of youth of color and youth who belong from other minority groups as well. The American Academy of Pediatrics attributes this empirically to two different things: differential treatment as they come in contact with law enforcement or with law enforcement or people who work through in their court system or through the correctional through the whole correctional system and process, that they might end up getting subjected to certain types of either implicit bias or differential treatment based on the fact that they are minorities, and that might end up explaining why we have such a disproportionate number. The other thing that they consider is the differential offending part, where kids who live in lower income communities and normally have a much heavier involvement with or have much heavier exposure to law enforcement at all times, and they are a lot likelier to end up getting exposed and then identified as somebody as an offender who might end up getting referred to the juvenile justice system. Racial bias has been documented in data that play a part in all of these cases at all points of youth process in the juvenile justice system. And then again, the large majority of them are male. If you see here, we have different percentages on cases being handled by juvenile courts across the nation. And the most updated data that we had was from 2020. We don't have anything that is current yet. So if you see the ethnic and racial backgrounds, you're going to see that there is minority children who identify with minority groups, especially racial minority groups, have a higher representation of children who are identified as white. And then again, we also have a higher representation of male over female, still of around the 70% of the kids. We have other groups that also have high representation. We have an increasing trend of girls and young women also coming in contact with juvenile justice, with law enforcement and juvenile justice services. We have children who identify as LGBTQ youth. We have children who who have experienced sexual exploitation commercially, previously known as sex trafficked. And then we also have the older adolescents and young adults to get included in here. And this comes from the fact that young adults are neurobiologically a lot closer to older teens in how they function and how they process things. And it might end up playing a part into why the American Academy of Pediatrics also is offering recommendations for them later down the line. We have data that does not show decreased recidivism or increase in rehabilitation from incarceration. Efforts have shifted from residential detention facilities to evidence-based community-oriented rehab programs, which is great. We're keeping these kids in the communities where they come from, which is closer to home, and maybe even at home. Detention facilities can be the first point of contact with healthcare services for a lot of these kids. And this is why we are talking today, because you're going to see in a little bit, we're going to talk a little bit about adverse childhood experiences, social determinants of health, and we are going to also highlight some of the data that we have available now that enrollment in primary care and having access to primary care services can be a protective factor against ending up in having issues with law enforcement or getting referred to the juvenile justice system as well. What is the bigger problem? Data is sparse. We have a hard time being able to, other than doing head counts, we have a hard time being able to address certain data gaps that we have, because as you can, anybody who is incarcerated or involved in correctional services is going to be a protected person. And then on top of that, these are children. So we have an added level of complexity that makes it really difficult for us to be able to study them, especially study them at a time when we are in the accessing the juvenile justice system services. So good thing is that, again, total numbers are decreasing. We are having a lot better numbers as of 2020, where we continue having trends of delinquency cases and caseloads going down, okay, for multiple things: drug possession, drugs, properties damage, public order, person-related, and then as well in total delinquency. The more current, some of this data probably got impacted by the fact that we were looking at the COVID pandemic, and then we probably had a little bit of a spike up, like we did with most other social determinant of health heavy related health indicators, but probably the overall trend should remain the same. We also have that most kids who end up getting referred to juvenile justice generally come from it's through contact with law enforcement, the more common causes why they get referred is because of drugs and property damage, theft and stuff like that. Thankfully, damage to other people is a little bit less frequent, but this doesn't go into that much detail about how much of these have more than one thing leading to their referral. Okay, and then again, children from certain minority groups are going to have an overrepresentation in also how when their cases get referred, and it might be because of the differential treatment and the overrepresentation of law enforcement in their communities. Overall, these cases are also going down. Like total numbers of delinquency cases have gone down, and in 2020 we had that 54% of all delinquency cases were petitioned for juvenile courts. Okay, you can see a different spread of what the different petition cases were about. Okay, but it doesn't say anything about if there was more than one offense there present or not. As you can see, 60% of them were identified as something other than white, and then 23% was identified as female. So that or were processed as female. So that also means that we have around the same percent, 70% of male representation here. We also have another piece of data here is that younger than 16 years of age are around half of the cases that were petitioned. So the other half was 16 and up, so closer to the older teen, young adult age. And then same things. This is going to look different depending on who the population is that you geographically serve. Okay, I can tell you from my experience when I used to work at our local detention facility here in Washoe, and most of the kids that I saw during my 2.5-year period there had Spanish last names. So they probably were, they might have identified as Latino or as Native American as well, given the local population that we have here in Washoe County. But this is going to look different based on where you geographically are. We know that the data that we have has shown that we normally have these children have worse physical, reproductive, and mental health outcomes overall, as well as most other long-term health indicators as well. We do have a higher incidence of chronic health conditions, including pulmonary infections and asthma, substance use and associated liver damage, maybe even leading to needing a liver transplant at some point, STI and genitourinary symptoms, dental problems, and we have a high overrepresentation of physical and emotional trauma. they are likelier, once they are released back into their communities, these children are likelier to suffer from community-based violence, either injury or death, as well as they are likely to be injured or die after detention from gun-specific violence. And this is, again, going to change depending on what your local demographic is. Common trends: poor primary and preventive care during childhood. We have a lot more emergency room usage and hospitalizations, both before and after. Okay, we have multiple sex partners and risky behaviors starting at an earlier age. We have a significant amount of early pregnancies. We have a lot of reports about non-consensual sex, as well as dating violence, especially reported mostly for, or more commonly reported by our children who identify as female, as well as children within the LGBTQ group. We know that involvement in justice system increases the risk for worse physical and mental health as an adult. And then there are standards of care recommended, okay, by the National Commission on Correctional Health. We have standards. These standards are not applied everywhere. There are a lot of different areas in the country where the standards are not accepted or acceptable or have not been established yet, or they might be incomplete in the way that they are using them. So mental health wise, we know that there are increased rates of depression, anxiety, conduct disorder as a previous diagnosis, attention deficit deficit disorder with or without hyperactivity, substance use, as well as having had a past episode of psychosis. We are likely to be admitted to the hospital for mental health inpatient management. We have higher rates of traumatic events, over 90%.
The two new cases that
over 90% of traumatic events, and most of those being violence reported against themselves or somebody in their vicinity. Girls and sexual minorities, much likelier to report multiple traumatic events, including sexual traumas and dating violence. We have higher rates of neglect, Department of Child and Family Services involvement, abuse, and overall adverse childhood experience scores, which I'm going to talk about separately in another slide. Yesterday, I saw a communication about how we have close to 400,000 children in foster care custody, and there is also, this is another group that is highly overrepresented within children who get involved in juvenile justice. We have higher rates than the general population of post-traumatic stress disorder, with severity of delinquency and more severe and numerous charges as well. And then we also have PTSD and we know that PTSD is also a long-term indicator for worse health outcomes. And then 25% of them already have another co-diagnosis that might end up complicating their mental health and increasing their mental health needs. So having given this overview and having talked about this population, I'm going to dig a little bit more into how some of these things happen and how they are common trends within this population group that we see again and again. So we know that teenagers have a different functioning brain than we do as adults. Normally, adolescence is where, or early adolescence is where most of that change happens, and then we end up having an evolving forward progress for social, emotional, biological, and cognitive development. We need in adulthood to be able to be functional, self-efficacy, increased agency, and assessment of risk-benefit levels. The brain matures and develops complex decision-making capacities, with the process extended towards age 25 in males and a little bit younger than for females. Positive attachment, when younger, leads to satisfaction and dopamine release, reinforcing positive behaviors, especially in the period of the first 3 years of life. That hug that a 3-year-old gets or a 2-year-old gets when they get scared, hungry, upset, or when something happens to them and somebody telling them everything is going to be all right, has an extremely positive impact on our reward pathways and leads to positive attachment. Okay, positive attachment meaning people going to people for comfort and for feedback. When we have experienced adversity, we can have altered sensitivity to dopamine in the rewarding pathways. So you might end up getting that same pathway that attachment at an early age can give you, getting triggered by different things, or just working in different ways. This can be in response to pleasurable, exciting, and stimulating experiences. Sometimes that can reinforce some of the risky and sensation-seeking behaviors that these kids have. This includes areas for executive and organizing functions in the brain that can mature later, closer to 25 years of age. When we have this present, okay, as well as we talk about as well as with some of the co-occurring mental health conditions like with ADHD, you can end up having a difference also in some of the impulse control as well as the attention areas, where you might end up having not the same response as other people do to both dopamine and norepinephrine, which are neurotransmitters that are needed for you to be for these areas to get activated and function. They might just work differently. All of this together can lead to risk assessment problems, favoring more immediate and stimulating rewards and lack of attention to consequences. Can lead to negative health choices. Again, most people who start smoking before 18 when their brain is doing all of this. And then if you think about it, if we end up having, for the first time in our lives, secondary to adversity, the only thing that we can depend on is on having nicotine trigger that pathway so we can feel better. That is the only consistent thing that we have in our life at that time that is actively stimulating and giving us a sense of well-being in a significant enough manner that you end up coming back to it. Traumatic experiences negatively affect a child's development, and this is how it generally happens. And then you can also end up having hyperreactive aggression and alertness when you have a past history of trauma, because your body stays locked in a fight or flight response at all times from most triggers. And then everything can become a trigger. So for our youth, we know that close to 90% of them, 90% or more have at least one form of childhood trauma that has been disclosed, with traumatic loss of bereavement being a lot more significant for young women than for young men, but it's still the majority of them. And then domestic violence being more persistent for young women than for young men. Again, over half of them report that. 75% of confined youth did not commit a violence offense, okay? But they were still in a place where they might have gotten differential treatment or some of the other things I referenced earlier. This slide is or this graph is a highlight on childhood trauma from the 70-30 campaign in Britain. All the data, the numbers are going to be a little bit different for the United States, but the information and the data is the same for us, okay? Childhood trauma is characterized as an event that a child finds overwhelmingly distressing or emotionally painful, often resulting in lasting mental health and physical effects. We know that there is a specific relation to past trauma, especially in those 3 years of life where you are unable to create an unsecure attachment with things, that is going to rewire not only how you do things, how you live, and what you avoid and respond to, with very well known long-term health complications, including general distrust of medical care. Sometimes even there has been data now that correlates trauma and then including intergenerational trauma with decreasing in vaccination rates or seeking primary care or establishing with primary care services. because you think that everybody is going to be out to get you. You are locked in fight or flight. 2 times more likely to develop depression, 3 times more likely to develop anxiety disorders. Common causes of trauma can be child abuse, physical, emotional, or sexual, grief. We have unsafe communities, highlighted here as war or terrorism, domestic violence, or either as the victim or as something that happens around you. Substance misuse, mental health conditions at home, as well as substance misuse by your caretakers. Separation. So how do we make sure that kids who end up going through the juvenile justice system don't end up getting further trauma or end up getting traumatized at the time when they are placed in correction? So it's a big question. We don't have the right answer for that one yet. Then we also encounter other forms of adversity, like bullying in schools and stuff like that. And the long-term impacts is that we take away our sense of safety. Okay, we sometimes end up getting a sense of helplessness. We create relationships, and we come to those relationships already with problems and make it more difficult for us to be able to sustain them long term. Fight or flight, freeze. We have different perceptions of reality and what's going on. Okay, so, and then we end up going into complex trauma, which is what happens when you have repetitive instances of trauma or prolonged trauma happening over a long period of time. And this comes with a whole different group of considerations as well. So trauma types among youth. This article is a little old, but they actually highlight a little bit more on the trauma type and percentage of youth through the juvenile justice system. And the reports have been that traumatic loss and bereavement were prominent for female at the time of this study. And then you end up getting people having multiple of these all the time. And then in the article, they don't talk that much about how that plays with more than one trauma. And then the other question that we have, or the other thing that we have, is we are now beginning to understand that intergenerational trauma also plays a part in family life, and how we might end up making choices for our healthcare and for other things. So what happens if we are living at home with somebody who has a history of trauma from, I don't know, being undocumented in the United States, and the fact that they feel that they are not welcome all the time, and being away from their home? So all of these things are considerations. I tried looking at data from kids who come from who are first generation in the United States, or who come from other countries and ended up in the juvenile justice system, and I couldn't find anything that correlates with those. So, but keep those in mind, because that is possible. That can be possible, especially for certain minority groups as well. And then when we talk about insecure attachment, we are talking about the link with further mental health concerns, as well as with substance abuse, with substance use disorders. We talk about adverse childhood experiences and leading to an insecure child attachment. And we end up having a different way of having a good feeling system, or activating the reward pathway for us to feel well. And sometimes the only consistent way that happens is through medication, is through nicotine, is through substances of abuse. So I wanted to highlight this slide there, because that way you can, I think that it ties together with the past history of trauma, as well as where we're going now, which is with the adverse childhood experiences. So these are traumatic events that can have negative lasting effects on health and well-being. And this is one of the bigger data, bigger basis of growing data, with the California Surgeon General a couple of years ago, likening the amount of data that was coming out and the things that we were discovering and linking to adverse childhood experiences and past trauma to the amount of information we were getting when antibiotics were coming on the market, or were coming into healthcare. So a lot of things are affected by for adult care as well as for children when they are unable to end up getting the care that they need in a safe environment. So it can happen through multiple things. There are multiple scores that we use here in the United States that we in primary care are trying to screen families for. But sadly, system-wise, implementation has been difficult, as a lot of different areas in the country don't have this included into what gets reimbursed from insurances. And even though it's the right thing to do, and we're trying to do it all the time, that not having reimbursement for it, it can lead to differences in implementation on this for most practices. And then there are communities also that just don't have the resources to be able to meet some of the things that we are talking about here. So we are talking about overall 3 large groups: abuse, neglect, and household changes, which with abuse, talking about emotional, sexual, and physical; neglect, talking about emotional and physical neglect; and then household changes, including domestic violence, substance abuse, mental illness, or mental health concerns, parental separation and divorce, and then parents who are in the correctional system as well. So, as you can see, all of these things come together. One thing that we are now starting to document here is going to be the impact of racism in certain communities, and as well as racism even in the delivery of healthcare, and how some of the choices get made on that basis, and trying to train physicians also on how not to follow that, and also change some of the systems that we have in place, because we do have systemic racism here in the United States at almost all levels in most environments. And then lastly, the other large one is going to be we are also adding community unrest as well as part of the household changes. Access to healthcare also is one that is right now being debated, but we don't have anything. People with six or more ACEs can die 20 years younger than other people, the people who have less would. And when you do the score, you end up seeing that you have the more adverse childhood experiences you can list on the person, the worse the health outcomes and mental health outcomes as well. So it's impressive. Okay, we know that the exposure to the lifespan to adverse childhood experiences lead to disrupted neurodevelopment, then to social, emotional, and cognitive impairment, adoption of health risk behaviors or risky behaviors, disease, disability, social problems, and then an early death. So that sounds a lot like the population that we were describing earlier. And this is a public health problem that we are barely able to meet right now, and we are trying to meet, especially through child care, and in some districts through adult interventions as well. And then it is linked to almost every single medical condition we can think about. We're talking about higher rates of for mental health conditions. We're talking about PTSD, eating and sleep disorders, suicide, depression, anxiety. We're talking about poor access to prenatal care. We're talking about pregnancy complications. We're talking about unintended adolescent pregnancy as well. We're talking about substance use as well. We're talking about alcohol use and other drugs. We're talking about like becoming nicotine addicted and smoking and vaping early. We're talking about perpetration of violence. We're talking about diabetes, cervical cancer, heart disease, chronic disease, everything. And then we talk about social determinants of health, which go hand in hand with all of this, because we have to understand that these are non-medical factors that influence health outcomes. These are conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions in which they do everything day to day. How your population looks is going to be different. One of the things that we talk about all the time here is, for example, is it safe, or is it, well, it's not safe. Are we okay with our state of Nevada having indoor pollution for everybody who works in the hospitality industry? especially in areas where children can't do. So why don't we have a full-on smoking ban there? So that thinking about that will end up feeding a little bit more into what social determinants of health are. And this includes social conditions and structural conditions, both social in your community and structural within your government, that should be viewed through an equity model that include data surveillance, evaluation, evidence building, partnerships and collaborations, community engagement, infrastructure and capacity, and policy and law. So we're talking about a full-on collaboration, and data is one of the big things that we are talking about. Again, data is sparse for youth in juvenile justice. So we don't know where, we have a hard time being able to characterize some of the more specific trends for us to be able to create interventions, because these are, like, youth are protected, and then incarcerated youth are even more protected from being able to do some of this. 80% of what impacts a person's health are non-clinical factors: socioeconomic, behaviors, and environment. You see all the time talk about global warming and access to water, and we're going to have a water scarcity soon. We have housing. We are living in a multi-unit household where you are getting secondhand smoke from somebody next door at all times. Do we have parks where we can exercise? Is it safe for us to be able to do that? Is it easier buying tobacco than actually going out to the park and walk? Do we have an education? Are we supporting families in the way that to meet their needs? So all of this plays a part. All of this plays a part. Okay. And again, these are things that our youth, if involved in primary care, we could have a way of better navigating it than we currently do. And then we didn't talk about poverty, because as when the other overall large trend is that we have an overrepresentation of children who live in families beneath the poverty line. And then we had COVID. I think COVID changed the way that the world works and the way that we are doing a lot of things. And nobody expected it. Nobody saw it coming. This happened from suddenly. So all of those things are different considerations for these populations that we have to find better ways of being able to identify and then assist with, or connect with, or try to talk to or try to find collaborations that will end up allowing us to get better data, and then maybe to be able to affect policy change at some point. So, care recommendations. 22 states in the whole country have a minimum age of involvement for juvenile justice correction as of February 2021. 3 states have set a minimum age of age 12. There is no legal minimum age in any way, shape, or form in the rest of the policies as of 2021 as well. Young children can be processed and adjudicated in juvenile courts, held in detention centers, and committed to correctional facilities. When we're talking about young children, we're talking about 12 and younger than 12 years of age. Okay, children are protected entities for research, and then incarcerated youth even more so. We also have to identify what happens when, for example, in our district, in our state, when you go into a correctional facility, Medicaid will not cover you, and my understanding is that this happens also across the country. So we have a lot of kids ending up relying on the budget that the correctional system has in place for them, no matter how long their stay, for seeking medical care, especially establishing preventive health or trying to make a beneficial health intervention. So not having coverage is really difficult, really difficult. How do we do healthy lifestyle modeling in there? Do we have any barriers to be able to stand continuity of care? In certain districts, I know that there are provisions where you are not allowed to talk to their PCP if they have one about a kid getting released back into the community, and you have to expect the family to make the effort of actually going there. And what happens if you have all of the other social determinants of health already present, where that might not happen, or that's unlikely to happen? Then we talk about children coming into correctional facilities at the national level. And and then, I don't know, they use nicotine products, they use vapes. Most kids that I saw here were either smoking or vaping or using marijuana. And we are just putting them and they're quitting cold turkey. And that might also happen with some of the kids who have been using fentanyl or some other opioid. Are we ensuring that they are getting that care and to be able to that might end up leading to long-term change for them? Other things that are difficult is the fact that we have a rotating gate on how long we stay within the facilities. We have a lot of fast turnover, and then lastly, what happens? How does your community look? We might have a community that if you have, especially with the younger kids, where you don't have anybody who can take care of children, or might not be comfortable. You might have family practitioners who got some training 25 years ago and haven't seen children for the last 20, and they are uncomfortable seeing kids, especially kids with complex behavioral needs. You might not have a larger referral center here if you have a kid with complex medical needs. So it's a very complicated standard, very complicated. In certain policies also, one thing that I didn't add here is that the part of the American Academy of Pediatrics recommendation is to also have, if gender affirming care has been started, to continue doing so while in correction facility, and that I have not seen as a problem, but I can see it being a problem given the current political climate, as well as where we are geographically. So things that we can do: establishing people in a medical home. That's going to be an easy one, really easy one. Look who you're partner up with, your local community or the community where these kids are going back to, or where they come from, and try to find more information and have somebody who has a clear idea of what the plan is going to be for follow-up and for management. And let your PCP, family practitioner, nurse practitioner, PA, pediatrician, being the person guiding care onward, but having it included in some of the discharge plans as well. Outpatient plans for complex behavioral and health issues. So maybe including the primary care provider as well as mental health is primary care, especially in communities like ours, especially in the states like here in Nevada, where we have a really hard time being able to meet the demands and the needs of what our population in the state looks like for children. And then on top of that, we also have our state is close to 30% Latino right now. And Latino families are the families that have a significantly high stigma against mental health care, which also will end up playing. So looking for who your partners are in those communities is really important. Talking about chronic disease prevention and getting enrolled, getting your Medicaid reactivated or reapplied for if you ended up going into the facility and it either expired or lapsed because you were in the facility before going out is also another priority that we need to have. Again, primary care providers being included can bring chronic disease prevention to the table as well. While we are delivering care for these kids, when we are in our hands, when they are under our care, talking about trauma-informed care and training, which I understand is part of the regular training that most people who work with juvenile justice involved youth currently do. But if you feel that either your implicit bias training is highlighting stuff and you are not sure how to manage that, or that something that you are doing might be worried, then locating somebody that you can talk to about some of the ways that you can do. If you feel that you can do things in a different way that might be better, then having somebody identified within your system that we can talk to about. In medicine, we have those people. Okay, and we get this training just like you guys do, because there is a lot of differential treatment in medicine, which right now the biggest ones in the news is going to be the fact that we have women who identify as African American have much higher mortality rates after delivering a baby, and that is attributed right now in the data to the fact that they are getting differential treatment based on their color of their skin, which is completely unacceptable. We are constantly looking at ways of being better and doing things in a better way. Cultural humility is a current practice also that is very like we are establishing as well in our in our in medical education, which basically means that the doctor doesn't know best.
Yeah.
Okay, you didn't have the lived experiences that the other person had. You don't have any authority as to why they make whatever choice, or they choose not to do a specific type of follow-up or care that they do. So treating the person that you are delivering care for, okay, as the authority figure on their culture and what they can do and see, or what they have seen, is really important. It can take a little bit of time to be able to establish this. I'm going to step back and I'm just going to ask you, so how come this happened? Or are we having any difficulties going there? What are you seeing here? So taking a step back and letting people in your care to actually be the authorities on why they make things the way that they do and how they do it and what choices they have available can end up leading to a lot of insight on everybody's part when trying to deliver care or services to them. The American Academy of Pediatrics and pediatricians across the country currently advocate for using incarceration as a last resort. Okay, and increasing diversion to appropriate community-based programs whenever possible, and when that person is not a safety risk for everybody else in that community. So those things are current things that we are advocating for at the national level. We are advancing policies and community action to address root causes of juvenile justice involvement. So again, trauma-informed care. We're talking about adverse childhood experiences. We're trying to tackle poverty. We're trying to tackle food insecurity. We're trying to tackle all the things that we just talked about before. We are trying to abolish excessive, punitive, and developmentally inappropriate practices, such as the use of life without parole for adolescents in the rare cases where youth are tried as adults, which thankfully is not the majority. We are advocating for changes within the current correctional practice that might end up leading to re-traumatizing kids. Confinement, solitary are going to be the two big ones. For one thing that already was removed in most, according to my data review on the correctional side, was also the use of restraints in female, which was also something that was caused a lot of trouble and a lot of trauma, especially for pregnant women, for pregnant kids in your care. State and federal laws can set a minimum age of 12 and up. Okay, you have a 6-year-old in there. Maybe there is a better place for that 6-year-old. And then what's going to happen to that 6-year-old when in that place, when you have all of these other kids there. The same thing goes for when you have a child tried as an adult and you end up in an adult facility. I know the current standard is to have him separated from most of from all of the adults all the time, but I don't know if that's happening everywhere all the time. Improve clinical care for youth in detention. So we have an opportunity for intervention if they have not been established with primary care, and then we also have a great opportunity for them to create the primary care connection, as well as encouraging them to go and have preventive care services from there, and including it as part of the plans for discharge definitely would be I think a good thing. And then all of these are going to look differently in where you live, in who you work with. The Office of Juvenile Justice and Delinquency Prevention also has other recommendations to treat children as children, to serve children at home with their families in their communities, and to open up opportunities for system-involved youth as their own advocates, and also as we call it a family voice or youth voice, for them to actually give feedback to us, because that's also going to be one of the bigger data gaps that we have right now. Things these are the same things. I just summarize them in a different ways. But they are, again, these are all based in who the population, who these children are, what the common trends are that we see between them, like between different at the national level. And then we also have to think about who we are serving within our community and what the diversity they can bring into how we apply some of these recommendations as well. Following standards of care when available would be a really good thing for it to happen nationally, and currently it's not happening all the time. Safe environment always. We need to have considerations for young adults to maybe, because they are likelier to, like, they're closer to teens rather than to full adults. So maybe that also changes a little bit of things given their biological buildup at the time. And then recommendations and advocacy, as well as policy change, leading to primary care access in your communities where you know there is a primary care shortage, to lead to change, so we can better help these families even before we end up getting exposed to any, or getting involved in any type of youth correctional facility. Thank you very much.
Thank you so much. I appreciate that. Now we're going to open it up for some questions. Feel free to unmute yourself, or you can put your questions in the chat, and we will pull them from there if you have something that you specifically want to ask.
I have a question. We are working on a capstone project for equity and justice, and I was wondering if I could get this PowerPoint as a resource, use it as a resource for those conversations that we're having right now. Do I just email you and request it, or would that be okay?
Yeah, I think that so long as Alicia and Lindsay are okay with that, I wouldn't have a problem with that.
Yeah, what we'll do is we'll attach it to the follow-up email that comes along after the presentation is wrapped, and that way you'll have access to it that way.
Thank you.
No problem. Yes, for Katie, who's asking in the chat if the recording and the slides will be available, yes, we will make both of them available. Once this is wrapped up, we'll send you out the information along with the link to the YouTube where it'll be posted, so you can access it there.
So thank you for the nice for the nice feedback in the chat. I'm reading it, and I know that Julian Allen had a question, has a comment about trauma goes back to the parent and what trauma they have as well. That's what I meant by talking about intergenerational trauma.
Yes.
And the same thing that with the immigrant families, including language barriers and things like that.
Then we have a question in the chat. Do you know of any work being done specific? Sorry, I lost it. Do you know of any work being done specific to how youth with disabilities end up experiencing the juvenile justice system?
To be honest, I don't. But a lot of the different mental health conditions that I elicited are approved as are approved for disability by at the federal level and at the state level. So I can look for that. I to be honest, I didn't find any data that connected both of those. But for example, I listed ADHD, and I know that there is a ADHD, one of the more common mental health diagnoses, and has severe anxiety disorders that disrupt kids' attendance to school, also can be applied for disability. And given the high amount of mental health of co-occurring mental health diagnosis in these children, I would say that there probably is a higher representation by them within those groups.
And we have another question from Alicia. Hi, I'd like to know if there is a national effort for transparency and accountability to gain federal funding. Are there national prevention efforts?
I am not currently involved in any, but there are groups that advocate for youth health that I have been in contact with over the last few months that are trying to prepare either policy statements or statements about certain forms of care for youth in juvenile justice. A lot of my background is on nicotine addiction and tobacco prevention, for example. And for me, the fact that we have this much time to put kids to talk to kids while they are in a correctional facility, and the fact that we either have to pay out of pocket for getting patches, gum lozenges, or getting the counseling going, the counseling piece for nicotine addiction, or that we are making them stop cold turkey the second that they come in, is going to end up negatively impacting their health as well. I have tried studying that here locally, and it's been difficult, but I'm getting right now some national entities actually trying to start talking a little bit more about it and offer it. And maybe there is going to be either a policy statement or a letter of or a white paper on some of these topics that can end up affecting long-term health. Remember that smoking is going to be the main cause of early death and preventable death. And even though we have only like between 20 to 15% of the population still smoking combustible tobaccos, e-cigarettes are right now the most commonly used nicotine delivery device by youth, and we have health complications from that as well. And then we are going to see a lot more show up over the next few years because they have been on the market for a short amount of time, so we don't have long-term data yet.
I just wanted to take a moment to say thank you again, Dr. Cucalon Calderon, for your presentation. For everyone that's participating, please remember, if you can give us a moment of your time to fill out the survey that's in the chat. We'll also put it in the follow-up email along with the presentation and the recording link. You'll also have the CLE or CEU information that's a part of that email. So if that's something that you need, you'll be able to get in contact with us and we'll help you through that process. It looks like we've come up on our time, but along with the presentation, you'll see the contact information for Dr. Cucalon Calderon. So if you have any additional questions, please feel free to send him an email with those questions. Again, we want to thank you for being here today. Thank you, Dr. Cucalon Calderon, and have a wonderful rest of your day.
Thank you, everybody, and thank you for the questions and for coming today.